Hi, everyone. My name is Scott Allen. I'm the CEO for the Family Medicine Education Consortium. I see some familiar faces and some new faces, so that's great. Glad you could join us tonight. We're going to hear about comprehensive family medicine and about the Forbes Family Medicine residency program of the Allegheny Health Network. So thank you, Dr. Nikoloff, for joining us tonight to share that information. Before we get started, I just want to say a few things about the FMEC for those of you who may not be familiar with us. We are a regional coalition that serves the Northeast US. We have about 14 states and the District of Columbia within our region. So it's basically the Northeast corner of the US. In that region, there are about 60 medical schools and 190 family medicine residency training programs. So we work with many of them, if not all of them, to help them do better training, to help their residents move into practice, and to help get medical students and others interested in family medicine and primary care. We do an annual meeting each fall, and I think a few of you may have been there just 2 weeks ago. We had that in Arlington, Virginia. We had over 800 people, including 89 family medicine residency training programs at our residency fair. So it was very successful, very energetic, and very nice to be getting together again after a couple of years of COVID. So hopefully if you were there, you had a good time. We also do some awards. We have some learning collaboratives that are around topics such as narrative medicine, low birth weight. We're trying to bring on new learning collaboratives all the time to help residency training programs and clinics connect in between our meeting and learn from each other. And there's ways to get involved with the FMEC. Really, our three focuses are to encourage medical students and others to move into family medicine and primary care, to help support residents during their training and also support them as they move out into practice by learning about different practice options and doing things like managing their debt and things like that. And also just to connect the family medicine residency training program so the faculty and the program directors can learn from each other and learn best practices and really feel energized about what they're teaching. And one more just quick plug, if you didn't get to our meeting 2 weeks ago in Arlington, Virginia, please plan to join us next year. We will be in Providence, Rhode Island, October 13th through the 15th of 2023. So with that, I'm going to stop sharing my slides and turn it over to Dr. Nikoloff.
Thank you very much, Scott. I appreciate it. It's nice to see everybody here. Good evening. How's everyone doing?
Good evening.
Everyone hear me okay? All right, I got the thumbs up. That's good. Perfect. So I really wanted to meet with you tonight. I am fortunate enough to be the program director at Forbes Family Medicine out here in Pittsburgh, Pennsylvania. And I'm just excited to sort of share our program a little bit with you and also to talk a little bit more about sort of what family medicine can be. I think there's some misconceptions out there, and I think that it's just sort of nice to give more detail and describe really how far you can go with family medicine. So that was sort of my goals for this evening. So anybody out in the crowd familiar with Pittsburgh? Okay, all right, a couple people. So I won't push you too hard, but I have a little Pittsburgh trivia for you. Let's see how you can do. So do you know how many bridges Pittsburgh has?
Saying in the downtown?
In the Pittsburgh area.
Close to 100.
Did you say close to 100?
Mm-hmm.
Okay. Anybody else want to venture a guess?
Maybe 50.
Okay. So Pittsburgh actually has 446 bridges. It's actually called the City of Bridges, and it has more bridges than any city in the whole world, including Venice, Italy, which nobody would ever expect. But literally when you come from the airport and you start to come through the tunnels, which there are lots of tunnels here too, immediately you're confronted with, the three rivers they're meeting at the point and lots of bridges. Every direction that you look, you see lots of bridges. So definitely the City of Bridges is an appropriate name. Anybody know a local actor who just won an Emmy for his lead performance in the show Dope Sick? He was also Batman at one point. I just remember that.
Michael Crichton?
Yes, that's right, exactly. So Michael Keaton, and he actually just thanked his parents and he mentioned Pittsburgh in his speech. So we were all very proud. one of our residency coordinators, Carol, actually went to high school with Frances McDormand. So that's like her claim to fame. They used to, hang out and be in clubs together and that kind of thing. So lots of sort of movies, lots of culture happening in Pittsburgh. And probably the last thing to mention is, does anyone know, because this is very important if you move to Pittsburgh, how many Super Bowl rings the Pittsburgh Steelers possess?
I'm gonna go with 20.
Wow, you are incredibly, that's very positive and optimistic. I love it. I hope that's the case at some point. No, but so far they have 6. So actually during the beginning of COVID, that was sort of how, stay 6 feet apart, just like our 6 rings, like that was kind of all over the airports and different things like that. So everybody's very aware here at this point of the 6 rings because of that, correlation that was going on sort of all over the place, during the pandemic. So so just to give you, a little bit of background, and hello for those of us or those of you who are just joining, give you a little bit of background. The Forbes Family Medicine Residency Program was established in 1978. So it's definitely well established, in the city of Pittsburgh. It's actually located in Monroeville, which is about 15-20 minutes east of the city, so not very far from downtown, but not a bad commute either, because it's reverse commute. So we all enjoy that and appreciate that. The population of Pittsburgh itself is about 302,000. And the population of Monroeville, which again is where Forbes Hospital is located, is about 29,000 people in the community, in the local community. So again, Forbes has been there for a very long time. Forbes Hospital is about 5 minutes from our office, sort of the main hub, which is in Monroeville. So that makes it really nice with regard to practicing, I think, because we can easily move back and forth, and the residents oftentimes will run over to the hospital, see a patient of theirs, or go meet, for lunch and come back to the office and that type of thing. So very convenient, from that perspective. We are an 888 unopposed program, and Forbes is approximately 300 beds. It's a level 2 trauma center, and really sort of the trauma hub in the east side of Pittsburgh. So, when there big things happening, they come to Forbes, and the residents are the ones that are taking care of those patients. It's definitely high volume, it's high acuity, sort of all levels of care. At Forbes itself, there's a rehab unit, there's a psychiatric unit, there is a newborn nursery and neonatal intensive care unit. So really, for a family medicine provider, it's a great place to practice because it spans sort of, everything from, newborns and special care nursery, all the way up to, our elderly folks who are, post-stroke, and we're taking care of them on the rehab unit and things of that nature. Also across the street from Forbes, I should point out that there is a nursing home facility there called Woodhaven, and the residents also see their patients there. So we really take pride in the fact that, the notion of continuity is very genuine, within our residency, and the residents themselves see patients in all of those different settings. So it's great for the patients and for the doctors, to be able to have that continuity piece and see their patients sort of all the way through. At the hospital, again, I said we were unopposed, and so that means essentially the residents run the show. And from my perspective, watching that, it fills me with incredible pride, to see them running the rapid response team. They're the first assist on every C-section that happens. When there's a neonatal resuscitation, they go to those deliveries and they help, resuscitate those babies. So we're also admitting, obviously, our patients and some patients for community docs as well. So it is a very busy place to be, but lots of opportunity there, for learning. And like I said, because we've been there so long, and because the residents, I think, are doing so much within the hospital, they get to know the specialists. We have a close relationship with our administrators, which you don't necessarily see all the time, and a lot of support, for our program because of that. So it's a really nice exchange that way. The residents, have the specialists' cell phone numbers, and they have theirs, and so it's really nice communication too, that you're not going through multiple levels and trying to sort of figure things out about patient care, you can pick up the phone and, call your GI colleague and say, hey, this person needs to be scoped and this is what we're finding. And, what do you think? And I think that makes for a really efficient team, in the hospital. I think all the residents would feel that, because the specialists also really like to teach. The intensivists are there 24 hours a day. They like to teach, and they're always there for backup. So even though the residents are running, the rapid response and going to the code blues, they never are non-supervised. When they need a hand, somebody's always there. And I think that's obviously really important to us, that they feel supported, through those things. So they have great experiences learning wise, but they also feel like they've got backup, and so I think that's really important. Questions that anybody has at the moment? Not yet? All right. So a couple of things, yeah, yes.
Hi, Dr. Nicola. Thank you
Hi.
for taking the opportunity and like sharing what the program is like.
Sure.
I have a quick question. So I'm an international medical graduate, but I'm also in the MPH program in New Jersey, and I see that you have specialty clinic for HIV and transgender care. But the program also mentions that we need to be within 3 years of medical school, like graduated within 3 years from med school. Do you also consider students that have a postgraduate degree after med school, and the year of graduation is more than 3 years?
Yes, we do. We do. Yes. I think we want to make sure that folks are having some type of experience, whether that be a clinical experience or going on to more training within the medical field, and absolutely we would consider, for sure.
Thank you so much.
Yeah, absolutely. Any other questions? Yes.
Okay, I'm from Pittsburgh, but I'm originally from India. I have students in Pittsburgh for my family,
Sure.
and I'm currently living in San Francisco. I have a question about your program. So are there any graduates in your program that are practicing both hospital medicine and primary care at the same time?
Yes, absolutely. So, that's really an interesting question, because the pendulum is sort of switching. I think that for a long time, folks either were doing, straight inpatient, like hospitalist medicine, or only wanted to be outpatient, and nowhere in between, and now that really is changing. Quite a few of our grads, a couple from last year and 3 of them actually from this year, who've really enjoyed their hospital experience, are looking now for positions where they can do outpatient medicine, but they also are part of a larger call group where they can go and see their patients in the hospital too. So for sure, we have a couple of residents from last year that actually went on to be hospitalists. And so they decided to do, purely inpatient. I think that, again, if that's something that you're interested in, then that's something that can definitely be accommodated as far as your experiences through residency and sort of building on that, and then networking, with some of the community doctors that do that, in order to obtain one of those positions, for sure. It's great to see. I mean, that was sort of the traditional family medicine model, is that you would round in the morning and, go to your office, or go to your office and round, later in the day. And I think people got away from that. But it does seem like it's swinging back in that direction, for sure.
Yeah.
Yeah, that's something that you're interested in?
Yeah, that is my long-term interest. I want to practice both primary care and hospital medicine at the same time, because I had the same experience in my clinical clerkships in the States, where my preceptors do morning hospital rounds and they practice primary care from afternoon to evening.
Right. Absolutely.
Beyond that quality.
Yeah, I think it's a matter of, looking where you practice, and how large of a group you're joining, so that you can both sort of take care of the office as well as, the hospital patients. But it's absolutely doable. And I think it's really great to see. We actually kind of go a step further and we do home visits as well. So a lot of our residents during their clinic will say, oh, we can identify these patients that either there's a transportation need, or, some reason, that they can't get into the office, or it's very difficult for them to get in the office. And so we'll set those up with our office manager and go and do a home visit for that patient. And typically either one of the faculty or one of the our office manager will go along with the resident and do a home visit. And the patients could not be more appreciative, obviously, for, having that degree of care. So it's very cool to see. Yes, you have a question? I see a couple hands up. Yeah.
Hi, Dr. Nikoloff.
Hi.
So my name is Julia. I'm a fourth year medical student at the University of Pittsburgh. So I've been around in the area for a while and very, very much in love with the city. So I was wondering if you could comment on, because I know every family medicine program is unique in their own way, and being an unopposed program in Monroeville, what is it like practicing in Monroeville as a resident?
Mm-hmm. Yeah, I mean, I think that the nice thing about where we're located is it's a very diverse population with regard to the demographic, the insurance coverage, the community needs. It definitely is full spectrum. So sometimes I think you go to specific areas where it's very adult heavy or very pediatric heavy. Ours is definitely full spectrum family medicine, and so it's a very even distribution, I would say, of age groups. It's also a nice distribution of, Medicaid, Medicare, commercial insurances, those types of things as well. Something I would add to that is at our program, we actually have 3 offices. And so as a resident, you rotate through all 3 of those practices. So the sort of hub is in Monroeville, which is what we were just talking about. And then we have a sister practice in Braddock, Pennsylvania, which is about 15 minutes or so from Monroeville. And that is an underserved area that is just really being rejuvenated. And so the residents love to rotate there as well, because again, it's a completely different experience and a completely different, patient population. There's a third practice that we just opened not too long ago, because again, we saw that there was a need. And so that is actually in Murraysville, which is 15 minutes sort of the other direction. And that's much more sort of women's health focused, a lot of like young families, moms and babies, more pediatrics, that type of thing. So I really feel confident about the skills that the residents develop, on the outpatient side, and learning sort of all those different techniques, depending on which patient population you're taking care of, given the fact that they get to go to 3 different sites like that.
Thank you.
Sure. Another question?
Yes.
Yeah.
Hello, Dr. Nikoloff. My name is Yemi, Nigerian trained physician. I live in Rockville, Maryland. Happy to be here. So I was wondering about I know your program, I read that your program is committed to the community. So I was wondering about the kind of community outreaches you have, because I love volunteering and giving back that way. So.
Definitely. No, and I think that, when we talk about family medicine, and we'll get into this a little bit more, but I think that that's a big reason that people choose family medicine or should choose family medicine, is really based on serving their community and being part of their community. And so from the beginning, we want the residents and even our students that rotate with us, to be part of those community events and experiences. I would say it's been great finally being back into the community, because I think everyone was really missing, those opportunities and times meeting up with patients and just with folks. So we are part of quite a few of the local schools. And so we're the school doc for a number of schools in the area. So we do their sports physicals. We have a sports medicine track at the residency. And so the sports medicine director, as well as the fellow and residents and students, go to the local schools, do sports physicals. They're the team docs for quite a few of the schools, and just supporting them, through any needs really that they have. We have close by, it is the Monroeville Senior Center. And I've gone there to give multiple talks, and it is packed. It's always unbelievable. Like, we think there are only gonna be a few people, and 50 people are in the room. And we did a dermatology talk actually right before the pandemic, and I went there with a resident, and we really did, just like dermatology and the geriatric patient, and specific rashes to that population. and it was very well received. Lots of people coming up to us after, showing us moles and whatnot, but we had a lot of fun, and I think they also enjoyed being there. We've done a lot of free community health screenings, and so actually we just did one last weekend, which was a free cancer screening for skin cancers, looking at moles and things of that nature. This past weekend we did walk with a doc. And so if patients from the community or people from the community wanted to sign up and just sort of have a conversation about their health, they came out and met up with a resident or faculty member, and we walked at Monroeville Park, which is sort of like a forest preserve that's close to the practice. And so that was a lot of fun. In Braddock specifically, we've done a lot of community outreach with just education with regard to blood pressure, with regard to access to care, and specifically during COVID, a lot of discussions on sort of the myths of the COVID vaccine and things like that in that community. So I think, we're always open up to new ideas as well, and so I rely on the residents quite a bit to say, hey, what events do you want to be involved with? We did the Heart Walk last year because somebody said, oh, I think we should do that, so we all went downtown and did the Heart Walk. And so again, anything you could kind of imagine, we're pretty open to trying. Yeah.
That's amazing. Thank you so much for sharing.
Of course. Yes. Yes. Question?
Good evening. I'm Gabrielle. I'm a third-year medical student from New York. I was just wondering, what sorts of procedures do residents get to do?
Yes, lots of procedures. So this is something that I think really surprises people going into family medicine that aren't sort of aware of it. And I think that it really distinguishes us in a lot of ways from our internal medicine and pediatric folks, that we work alongside. So at our centers, we do lots of skin procedures, which I'm going to do a plug here. Next week, 2 of our faculty are doing dermatology and family medicine. So if you guys are free, Dr. Joya and Dr. Irwin are going to be talking about that and which specific derm procedures we do. But we do lots of punch biopsies, shave biopsies. We do, elliptical incisions, we do INDs. And actually, this was sort of a cool thing that just started this year where, the dermatologists are always really bogged down, right, in their office, and they're really busy seeing patients in their office. And so the residents wanted more experience with, getting procedures. And what we were finding was in the hospital, a lot of times we'd see patients and they would, develop a rash or have a rash. And we'd be waiting on the dermatologist to come in to do the biopsy to kind of help us, determine what the proper management would be. And so we came up with this idea and said, we know how to do biopsies, why can't we do the biopsy and sort of collaborate with one of the dermatologists outside who could do just like an e-consult, we could talk about the case, with him or her, but we did the biopsy and submit that to pathology. So that's been going wonderfully. They love it because that takes that piece, off of their plate. They're still, doing that consultation and working with the resident, and the residents get all of that experience. So we're doing that in the hospital. Other procedures, lots of women's health procedures. So colposcopies, endometrial biopsies, Nexplanon, IUDs. Those are probably the bigger like gynae procedures that we do in the office. Having the sports medicine track, we just started point of care ultrasound. So that's really new this year. We're sort of developing an entire curriculum around that, which is very interesting because a lot of us haven't had that experience. So we're learning too, with some of the newer faculty that have done that pretty much throughout, So we're doing that on the inpatient and outpatient side. We do OMT. So we have 2 half days that are designated for osteopathic manipulation treatment. Residents can sort of sprinkle that into their own clinics as well, but we have those 2 dedicated half days so that we, know that you're getting that experience and having one of the faculty there to supervise, those clinics. Splinting, casting, those are a couple of things. We have a sports track, so they're doing a lot of joint injections and things like that, sometimes with that ultrasound guidance like we had mentioned earlier. So there's quite a bit. circumcisions. We just had 2 circumcisions today. So again, we really try to be proactive and, keep our patients at the office. I mean, we do things that we can do, without trying to always sort of ship them out to gynae to do the colposcopy or sending them to P's to do the circumcision. We really, have such a sort of diverse group of faculty that have lots of different interests. And so we can really keep a lot of that stuff in-house, which I think when you're training, you want to be able to do it there and do it with your faculty. So lots of procedures.
For the OMT procedures, is that just for the DO graduates, or can MD graduates also learn some techniques?
Yeah, no, we want the MDs to learn it too. We encourage them to do it. Typically what happens is in the beginning of intern year during orientation, we sort of introduce OMT, talk about some of the principles, and get everybody sort of familiar so that you have an idea of what that is. We actually have an OMT track just for allopathic folks that are coming in and sort of want to learn that skill and want to learn those techniques. And then we basically just incorporate them into those clinics with senior residents that can kind of help, supervise, teach them some of the techniques. We do OMT workshops once a month and everybody, comes to those. So again, there's definitely lots of opportunity either way. Yeah, I encourage that.
Thank you.
Sure.
Hi, Dr. Nikolov. I have a question.
Sure.
So I'm a medical student from India, and my question was, how are the graduates after residency? Do they usually go straight into full-time, or do they go into academics, or do they stay within the area of Pittsburgh afterward?
Yeah, that varies so greatly from year to year. It's unbelievable to me, actually. For example, last year, 2 years ago, we had a resident who left and went right into academic medicine in New York. We had another resident who went into academic medicine further out, like in Ohio, and then lots of in between. So people going into group practices. We have some folks that went into hospitalist medicine. This past year, we had a resident that went back to her home state of Utah to do a women's health fellowship. So she's doing C-sections and all that kind of stuff now. And 3 of our residents last year did sports medicine fellowships. The others, 1 did hospitalist and 2 did outpatient. So it's really varied from year to year. This year is completely different. This year we have, 8 residents, obviously in their 3rd year, 4 of which are for sure wanting to go into outpatient medicine, like want to join practices. They're actually all staying with AHN local in the area, which I think that's wonderful, that they are happy enough to want to stay, and we're certainly happy enough to want to keep them. So they're staying in the area. 3 that I had mentioned earlier are trying to look at specific practices that are doing hospital and outpatient because they really want to do that mix. And then we have 1 who's looking into a fellowship. So it really depends. But I will say that it's important to me, and I think it's important to the faculty that, we're investing so much time and energy, in the residents, and we want them to stick around, so when it comes to looking for jobs and that type of thing, if we can fit them somewhere, within AHN, even if it's not in Pittsburgh, if that's not where they want to be, but we try our best to retain our residents that we've trained, because why wouldn't we? It's great to still have them within that community of docs. So yeah.
Thank you.
Sure.
If I may, I would like to ask a follow-up question on that. So do the residents, or in the more recent years, have residents graduated and stayed on as faculty at Forbes?
Actually, they have. So that's an interesting question. We've recently, so 3 years ago now, my God, I feel like time's flying by, but 3 years ago, we had one of our faculty who was very interested, or one of our residents rather, who was very interested in underserved medicine. And she just really planted herself at Braddock. She loved being there. The patients loved her, and she was growing this huge practice there. She's done a ton of community outreach, and it just made sense. She said, I would really like to stay on as faculty and be sort of that core person over at Braddock. And so she is. So she's been there for 3 years. 2 years ago, we had a resident, Dr. Ferenchik, who's wonderful. And he was excellent teacher, just amazing. We would watch him with the students, we would watch him with his junior residents. He was our chief, his 3rd year, and he really wanted to stay on to do academic medicine. And so he is. So he's there as well. And then this year, one of our sports medicine faculty from last year left to become a program director himself. And so we had a sports medicine faculty position open. And so our last graduate from the fellowship actually is now on as faculty. So absolutely. I mean, I think that, again, we're training, great docs. We want to keep them and retain them. And I think that, if you show interest early on and wanting to pursue academic medicine, then we can help you with faculty development and things like that over the course of your residency. Something that sort of pertains to that, which I think is a really neat idea. And this was started way before me, so I can't claim it, although I would like to. We have something at our residency called a longitudinal. And so starting out the second half of your intern year, all the way through the end of your 3rd year, 1 half day a week, you are allowed to essentially choose what you want to do. And so the residents, a lot of them do, if they're interested in teaching and in academic medicine, they'll say, I want to do a faculty development rotation, or they've just come up with recently a teaching elective. And so they're going to the inpatient service in the morning and doing a topic every morning for the inpatient team. They come and co-precept with us, and, while we're teaching the residents, we kind of let them take the lead, and then we add things in, as need be. And they also help out with a lot of projects with the medical students and with some research. So again, if that's something you're interested in, I tell people from the get-go, sort of let us know, because we can kind of help to grow that, over the course of your training, for sure.
Thank you. That sounds amazing.
Sure.
I think it speaks volume when people stay on and continue to be part of the same community. That's very
Absolutely.
special. Thank you.
Yeah, thank you. Thanks for the question. Yeah, the longitudinal too, just to expand on that, I mean, it's well received by the residents. They love it. And a lot of them, some of them will stay on. So for example, if they know there's a practice in the community that they would really like to work with in the future, they will ask that practice, hey, can I come do my longitudinal with you, on Wednesday afternoons, or that type of thing, over the next 3 months, or over the next 6 months. And that way they get to know the practice gets to know them. And then when it's time to look for jobs, it's like, hey, we've already worked together, that type of thing. And so that's a really nice sort of networking opportunity for the residents. Some of them, do electives in sports because they want to do sports medicine. Some of them, do electives. I had one resident who, he was great. He was moving back to Canada. This is right when I actually started at Forbes. And he was going back to Canada, and he said, I really want to do a lot of dermatology back in Canada because there are really not very many dermatologists there. And so I think it's a great niche, for me, and I want to learn more. And he said, I want to include cosmetic dermatology, which he said, I've never learned. So he said, if I go take a Botox class, would you go take a Botox class? And we'll start a Botox clinic at the Family Medicine Center on Thursday afternoons. And I thought, well, this is wild. What am I've never done this, that type of thing. But I said, hey, let's try it. It's a new skill. I've never learned that, so I took a class actually out in Chicago. He took a class out near here. And we met up and started a Botox clinic on Thursday afternoons for the last 6 months of his residency. We had lots of volunteers. a lot of the staff and the residents were like, hey, I got a little something here, that type of thing. But he's using it now in Canada, which I think is just really cool, so everybody's pretty open to ideas. If you've got an idea and something that you're passionate about, pretty much any of the faculty, somebody's going to say, okay, I'll jump on board and try that with you. So it's a neat thing for the residents.
And just one more question.
Yeah.
how does your program screens applicants like during this residency season? Or they basically look for the scores or personal statement, like what aspects they consider more when they're looking at that?
Yeah, well, that's funny you mentioned that because ARIS for the program's open today. So I logged in about an hour after ARIS opened, and I think we had 600 applicants after 1 hour. So I was like, oh boy, here we go. Like let the games begin. You know, it's a whole new season. No, I think the scores are obviously very important. I think your training and your grades and all those things are very important. But that's not all we look at, for sure. That's not all we look at. And actually, it's one of the last things I look at, because I think that to be a great family doc, you do not have to be the top scorer. I think that there's so much to be said about who you are as an individual, what your letters of recommendation look like. I think that's really important. I think that's very telling, as to your work ethic and those types of things. I think that your personal statement is something that we read every single personal statement, when these are coming through and we're looking at folks. So I think it's the whole picture, it's not just the score. I think that that's part of it, of course, but that's definitely not it. It for sure is sort of the big picture. And we look at all of those things, just like you do when you're looking at programs, right? You look at all of the big picture stuff, but then some of the details, but I think that, I don't know, that, like I said, the personal statement and the letters of recommendation, I think we find extremely valuable. And if the residents have worked with you, that's something else, right? It's like, oh, I worked with so-and-so on, my OB rotation, and here she was great, then, I mean, that goes a long way too, because that's, a personal experience. Starting that whole process all over again. It's unbelievable. Day one. But it's good. It's good. So some of the other things that I just wanted to kind of, put out there for you to think about, why do you think a lot of people go into family medicine?
I mean, from my side, I see like family physician has like opportunity to interact with diverse patient populations, like from different age backgrounds, and basically they can diagnose and treat patient in first hand without needing any help. But they're like the frontline worker for every patient, like patients on their family. That's my main core value why I want to be a family physician. But after that, like if you're really interested in specific specialties like hospital medicine, geriatrics, you have that options. But I'm not into more of it. But why I choose family medicine is because of diagnose and treat patients in the first hand without needing help of anybody. That's my most core value why I want to be a family physician.
Sure.
If
That's absolutely true. We are first line for sure.
Yeah, my perspective on it is like, we don't discriminate. It's like whoever walks that door into our clinic, we care about them, irrespective of what age group they are. From cradle to grave, everyone is treated the same way. And the other thing is, we don't want to like just treat the patient. We also want to give them the preventive care. We also want to educate them, take that opportunity to counsel them in the right way, so that they maintain an optimum level of health and promote that health throughout their lifetime. That's probably how I see it.
Absolutely. That's a great way to see it. Yeah, and that sort of was what I wanted to, bring up. We hear a lot of things, when people are applying. I'm a people person. I like the variety of family medicine. I've had some folks say, well, I just liked everything. So I just decided this is what I would do, because I didn't want to leave anything out, and not that any of those are bad reasons, but I think that some of the things that you just pointed out, make a lot of sense. And I think that the other thing to consider that people that are sort of starting out in training don't recognize is, I think, the future of medicine, right? So we're where we are now, and we know what the past was, but the future really of medicine has so much to do with population health, and I think that, again, as family physicians, we're looking, at health status and health outcomes within a group, not even just one person, but within the group and the community, and we're always sort of moving forward, assessing the needs of our community in order to do that, and I think that we're one of the only groups, or one of the leading groups, I should say, that really has such a strong, sort of strong force, a big responsibility when it comes to population health, because of being frontline and because of, taking care of everybody, walking through the door, but also looking at the big picture, which is the population and the health of our communities. Have you all heard of population health or been taught that in school at all? I'm just curious.
So right now, since I'm in LGBTQ health concentration in my MPH program, the discussion is more around the LGBTQ community and what are the health disparities and what they expect from the healthcare system. But a major part of it also talks about what are the community needs, like how do we assess them, and what are the programs that we could come up for these communities that have special needs. Like the underserved community has different needs compared to probably the immigrant population who don't have any background knowledge of how the US healthcare system looks like, or maybe don't have insurance. Then what can we do for them? So something on those lines.
Absolutely. Yeah. And right, because you have to be looking, at different needs of different communities and what those disparities are. We just talked, I was at FMEC actually at the conference. I went to a talk on this because one of the, so the family medicine ACGME requirements are changing this year. They're sort of not, I don't think probably drastically. I think most of the changes are going to be positive. One of them though is to incorporate for the first time a community advisory council. And so that would, that would mean bringing in community leaders, bringing in patients, bringing in residents, bringing in, all these different people onto sort of a panel to help assess, okay, what really are the needs of the community and are we meeting them? We don't want to be the folks that say, oh, I think this is what the community needs, and really in the background, they're saying, that's not really important to us. This is where it's at. So we had a discussion about that with one of our neighboring residencies, and they were doing their absolute best. And they said, it's transportation. We know that transportation has got to be the number one issue. And so they were talking to, transportation, local authorities and figuring out buses and doing all of this stuff, which was incredibly valuable. But then when they put this council together, they said, it's food insecurity. Like, that's not as big of a deal to us. This is what we need to be working on, so it's just, I think that's going to be a great thing. And we're sort of working on gathering who we want to be, part of that council. But again, really assessing the needs, and sort of not guessing the way you think it is, right?
Something on those lines, a tagline that we use in our classes is like, nothing for me without me. So if you're making something for me, if you're developing something for me, you have to include me or people like me during the decision-making process. So that's
great. Oh, that's great. I love that. I'm gonna have to remember that. That's really great. That makes so much sense too, right? So I think that one of the things to point out too, to all of you, and again, it depends on your interests. The residents are trained in all of these things. They're sort of just naturally incorporated into the residency program. But I think that, we think of family medicine, right, as being preventative care. We think of it as, educating our patients and chronic disease, management, well child and well adult, visits. But there is so much more. There is so much more to offer, and there's so much more to learn. And some of the things, just to point out that I think are just really interesting that we're doing because of needs assessments, within the community. So we have a family-centered maternity care within the residency. And so these are family docs, that are looking at the whole laboring experience very differently and looking at the prenatal care in a very natural sort of holistic way, with those patients. And the residents are those continuity docs, for those patients. And I think they find it incredibly valuable to see both sides of things. They work with the obstetricians, but then they also see this family-centered maternity care with, our patients that they're taking care of. they're learning MOUD. So they're doing, medication for opioid use disorders. So we have an MOUD clinic every week. And one of our providers, she actually just won the Family Physician of the Year this past year through the AAFP, Dr. Anderson. She has sort of been instrumental, in that teaching and in taking care of those patients all over the city of Pittsburgh, including the correctional facilities, the midwife center. She's just incredible with regard to the community and outreach within, that particular, like I said, everybody's sort of got their passions, and that's definitely hers. We have an HIV positive clinic. So Dr. Wolf, who's one of our faculty, he does transgender care and he does HIV positive clinics at the center. So a half day each, per week, he's taking residents through those rotations. He takes the med students with him as well. And again, that's something, that, like you were just saying, there's a need, there's a health disparity there, and he's filling that, for our community. So I don't know, I value that. And I think that the residents don't even recognize it because they're just kind of flowing through their day and like, what am I doing in the morning? I'm in positive clinic in the morning and I'm doing MOUD in the afternoon. And then they're just kind of in it. And so I think that once they leave, and we put those graduate surveys out and we say, hey, how do you feel about managing, Suboxone? And they go, fine, like no problem. They're teaching people when they go into, outside practices, like, no, this is what you do. And this is, they're sort of leading the way. So we're doing some of those things. We have specific pathways at our clinic too. So we do a diabetes pathway, we do an obesity pathway. And the cool thing about those is it's multidisciplinary. So we have a full-time pharmacist, we have a dietitian, we have a social worker, a behavioralist, and all these people that come together to work those pathways together and see those patients along with the residents. So again, it's just sort of incorporated in. It's like, oh, it's Monday afternoon, I'm doing the pathway today, and again, just really cool things that, even for me having, been doing this a while, it was interesting, but at my previous residency that I was at, we didn't do MOUD. And so coming here, I was like, oh my gosh, like, I don't know why we weren't doing that. And this is incredible. And there's such a need, and so Dr. Anderson taught me how to do it, when I started here. And now I'm comfortable, doing that. So again, there's all of these sort of mini clinics, if you will, within the actual clinic that just broadens the diversity of what you can do within family medicine that I don't know, I love that about the program. And I love, sharing that with the residents and the medical students that are coming through. Have any of you had experiences with any of those different fields within family medicine? A little bit maybe, but sounds like not a whole lot at this point, right?
Not really, if I'm being
Yeah.
honest.
Not so much.
Yeah. I mean, I think that I don't know. I hope that is incorporated more into, medical school training and that type of thing. But at least coming out, of med school and becoming a resident, that you have that exposure, to all of those things, because again, there's going to be a need, and even continuing that momentum forward is when you are part of that council or you're part of those community assessments, to learn those things and to put yourself out there, so that you can meet those needs within your community. Yeah, you have a question?
No, I just wanted to, since you asked the question, so in my previous rotation in Michigan, we had this a physician who also worked in addiction medicine. So I think Michigan already has a high level of opioid dependent patients, so they do have it. But I could see, like, with the increasing patients that we see dependent on opioid, and every other patient that comes in the ER has to be given naloxone. So we do need training that when we step out of the residency program, we are competent enough to handle these cases that come.
Absolutely. Right. And especially depending on where you end up practicing, there may be a Suboxone clinic down the street that you can refer them to, but there very well may not be, and so again, I think that the more you learn sort of internally and the more that you can do for your patients within your particular practice, the better off they are, and also the better off you are, as far as your patient population, for sure. We actually had a really interesting case. This is a couple years ago, and he was a patient that came to see me. He had been in prison and had just gotten out and did not have a PCP. And so he came to see me as a new patient, and he said, I know that I have hepatitis C. They told me that when I was, in prison. I don't really know much about that. All I know, it's not good. And it's affecting my liver, they told me, and I need to do something about it. And so I'm sitting there and I'm talking to him, and he's living with his sister, and he doesn't have a job yet, and he doesn't really have transportation. And I'm thinking, how am I going to send him to a lab, to get multiple lab draws, to a GI specialist, to the hospital to get imaging, I'm thinking this through as he's, talking to me. And so I said, give me a few minutes, I'll come back. And I went and I talked to our social worker, and I talked to our pharmacist, and kind of pulled them together. And I said, this doesn't seem that hard to treat, right? I mean, there are certain medications, we'd have to follow him, we'd have to do lab draws, we would have to do phone visits, for some of this stuff, because again, transportation's a big issue for him, potential home visit down the road, but I think we could do it. Do you think we could do it? And they said, I think we should try it. And so we developed a protocol around this particular patient for hepatitis C treatment. And it was amazing. I mean, everyone kind of pulled together. The social worker helped with regard to, doing phone visits, calling him. The pharmacist found the medication for him at the best possible cost, which was unbelievable to me. I was following up with him with his labs and kind of doing that. And 12 weeks later, he was hepatitis C free. And we couldn't believe it, that this was just, and now we have a hepatitis C pathway, so again, now we have a population of patients that are coming in with that, and we feel comfortable treating. Actually, at last year's FMEC, we presented it and did a write-up in the AAFP about a patient's perspective on that. We interviewed him, and he gave us his thoughts on that in one of the close-ups, they call it, through the AAFP. So it's just like really, really neat, to watch that whole thing transpire, and then see all these other patients now, being taken care of because of just that one case, it's just that one case, but now we have many. So what other questions do you have? Anything?
Well, I just thought that was an amazing story of how one patient has led to the treatment of other patients. And I feel like that's what family medicine is. We can't be everything to our patients because they need us to be.
That's right.
Yeah, so I thought that was an amazing story.
Oh, thank you. Yeah, it's really neat when you see those things come together, and sort of the whole team working together to sort of come up with a solution, for a patient. There's nothing better than that, and the residents were a big part of that too. So it's great to see that. One other thing that I would just point out, and sort of like piggybacking off of that, is, I think that a lot of times family medicine physicians, at least in my experience, have not been very research centered. That hasn't been sort of a strength as far as, I don't know, my past experiences and working with a lot of family docs. And I think that is really changing. And I'm so glad it's changing. I think that a lot of times these ideas, right? So doing some research, on a patient like that, or a group of patients like that, or a lot of times where our research comes in is sort of centered around quality improvement, and I love those projects that we do with the residents, because I think that it helps the patients, it helps the center, it helps us to learn. We just did a presentation at the FMEC this year. It was a poster on VTE transitions of care. So we're sort of still working on it, but this has been a quality improvement project that I've been working on with the residents, where patients that are admitted to the hospital or to the ER and diagnosed with a VTE, so either a PE or DVT, we were following them and watching that those patients would get readmitted, with another clot or with a, medication issue or an adverse effect. And we were like, what is going on, with these patients? Why does this keep happening? And so we started to dig deeper and sort of recognize that it wasn't their care in the hospital, but it was that transition of care that was lacking, So did anyone check back up with them to say, how's that medication going? Or can you afford it? I mean, a lot of times emergency rooms will give like starter packs, of the DOACs and these medications, but, they are done in 30 days and then they're like, I couldn't afford it, so, and they don't necessarily tell anyone, or I didn't know I was supposed to get my INR checked. And now I came back to the hospital with a bleeding event because my INR is 6, but I didn't know I was supposed to do that, or they forgot or what have you. So we are studying now that transition of care. And the residents were awesome. They implemented all these different things. So we're in the process of creating an educational video that the patient watches before they leave the video on the management of VTE. They also, now we do a 48-hour phone call to the patient. So it's like a transition of care phone call just to see how they're doing. And then a couple weeks after that, there's another phone call. We then have them come in. So like a month later, essentially, they come into the office and the residents created a VTE dot phrase or smart phrase, which all of you are, I'm sure, much more skilled at than I am. But the residents created this through Epic. And so when a patient like that comes in, they punch in .VTE, FFM, and there's a checklist that comes up. And so that way, you're not missing anything with talking to the patient, like, did you need a hematology follow-up? Can you afford the medication? Where are you at with your medicine? And those types of things. So it's really neat to see sort of that unfolding. And so far, we've been pretty successful at keeping people out of the hospital. We chose 45 days as sort of our marker of when we wanted to reevaluate folks to see. And so far, so good. So next year at FMEC, we hope to have the results of sort of this year compared to last year. But again, I think that that's where a lot of these projects come from, are just ideas, or seeing these folks coming back to the hospital for one reason or another, or an interesting case that maybe somebody doesn't know about. And so we really encourage the residents to do those projects, and the faculty join them, to work on those projects.
I think something off of that, even like, since many of the candidates who are from MPH have like research background, they have really taken family medicine into the research perspective.
Right.
Now, during I'm working currently at the Rutgers Student Clinic. So we try to, and there is a lot of student population that are not vaccinated for the HPV vaccine. So we are trying to do that quality assurance project where we try to see how many students are not vaccinated, and the physician really counsels them, and then how many of them really did go back to take HPV vaccine and did get back to us to see how much of a difference the physician makes when they counsel them on vaccines like HPV vaccine, which is probably not one of those mandatory ones. So family physicians are probably those that have real access to the community and can make difference, like bringing the changes in the policies or treatment guidelines and or everything on those lines.
Absolutely. Yep,
Yeah.
absolutely.
A question that I have, sorry. So thinking of going back, since the website had mentioned that it does not, the program does not consider graduates who are more than 3 years or 3 years within the med school, I did not apply. Does the program also consider applicants that came late after today's date?
I don't understand the question.
So, I was interested in your program, but I did not consider applying because the criteria on the website mentioned that if you're more than 3 years out of med school, we do not consider them. So I did not apply to the program. If my application comes out late, do you consider rolling applications that come to the program?
Oh, sure. Absolutely. Yeah, absolutely. Yes.
Yes.
Definitely.
Thank you.
Yes, for sure. Any other questions anyone has about the application process or the interview process or anything? We can kind of open it up here. That's sort of all I had. So if you have any other questions about any of that stuff, I'm happy to answer it for you too before we wrap up here.
Yeah. Is your program doing virtual or hybrid this year?
What is I'm sorry?
Is your program doing interviews by virtual or by hybrid, like in person?
Oh, yes, yes. We're doing virtual this year.
Completely virtual.
Yeah, I will say though, so the interviews are completely virtual, and that was sort of mandated just through AHN for this year for the programs, because I'd love to do it in person again. But they did say that we could do second looks. So, you know, if you do the virtual interview and then you want to come and take a tour of the clinic or the hospital, we can certainly do that. And so we're able to do second looks. The other thing is, fingers crossed, you know, that this pandemic doesn't come back to get us, but we want to do an end of season applicant party with everyone too. So just more of a social, you know, not a formal interview process, but kind of, you know, meet and greet and spend some time, you know, with the residents and the faculty, just getting to know them, you know, on a social level. So those two things are sort of definitely able to be done, but the interview themselves are going to be virtual. Yes.
Understood.
How do you all feel about that? I'm just curious. You know, I know you haven't experienced the other, but, you know, in talking to people, do you think most folks are happy with doing the virtual interviews, or what do you think about that?
So, talking from experiences from other international students, since they have to travel from foreign countries to, so that saves a lot of money, I
Mhm.
think, and the flight issues and everything if they get canceled. So I think on that part it's good, but it's good to have a personal touch. It really tells about the program, the residents in there, and like how the hospital looks like, what the area in the proximity looks like. So I think it's a good idea that we do the like second looks, so that at least the applicants get to see, or like those who have interviewed get to see how it feels in person. So that's
Sure.
a great thing, I guess.
Yeah.
It is especially true if people are living in Pittsburgh.
Yeah, I mean, I think it's very challenging, you know. We love to meet people in person too, but I get the financial burden of traveling and, you know, that type of thing, for sure. So that's why that's kind of a hybrid in a way. You know, we're trying to say, okay, virtual interview, but you have this opportunity if you want it, you know. And again, that's really, and we stress this to all of the applicants, you know, that we interview, is your ranking does not in any way rely on if you come for a second look or not, you know, because I know there are a lot of barriers to that, and rotations and whatnot, you know, so it's available to you, but it's certainly not mandatory.
So I was wondering if I could switch that to you. Like, you have interviewed people virtually and you've met people in person. Have you regretted recruiting somebody you have not physically met since the virtual interviews started?
Yeah, you know, I think that during the first year that we did virtual interviews, all of the program directors were very high anxiety or high alert about that, you know, because I think you do get to know someone sitting in a room having a cup of coffee with them and watching them interact with, you know, the residency coordinator and, you know, the other residents around and that type of thing. I have to say though, I have not regretted anyone that I've matched, you know, or ranked. That we met virtually versus in person. So I'm happily, you know, I can happily report that no, we haven't had any regrets yet. No, I think that so far it's gone really well. And actually, I think a lot of the program directors, you know, we commented on this sort of as a group, and I haven't really heard much of that. I think people are really still very happy with who they end up matching. I think we feel for the applicants because, you know, when we were interviewing and looking at programs, you know, I mean, times have obviously changed greatly since I did that, but, you know, I feel it's a hardship for some of you. I can't imagine choosing to move somewhere, you know, for a period of my life and have never been there, you know, having never been there. So I feel like that's really tricky from your side of things. And really, you know, that's a lot of trust, you know, that you put into the programs and the people at the programs to say, okay, I'm doing it. I'm moving to Pittsburgh, you know, or wherever it is. Especially if you're not familiar with the area, you know, that's got to be a challenge for all of you.
And I agree with you because when you started, I was picturing the bridges and the rivers. So yeah, it would be nice to come down to
That's
Pittsburgh
right.
and see.
I had a question about if we were to get an interview, how would the day go if we would have time to talk with other members of the faculty as well as the other members of the resident, like in the
Absolutely.
hospital?
Yeah. So typically the way we do it, and I think it's been pretty well received. Usually what we do is the night before there's a social hour with the residents. So there'll be a group of residents assigned. They'll log on just sort of like we're doing right now and just chat, sort of get to know you. You can ask them questions and get to know them, but it's purely sort of a social engagement. So no interview questions or anything like that. You can watch how they interact though, I think, which is fun to see, and helpful to kind of get like the culture of the program and sort of the vibe, within the residents. So we always do that. And I know the applicants seem to really enjoy it. The next morning, usually we start out and Gina Sacco, who's our residency coordinator, does an introduction, kind of talks to you about specific items within the curriculum. She talks about sort of, evaluations. She talks to you more about the hospital, some of your rotations, those types of things, and gives you just sort of a general overview on the program. And then we start to divide up into individual meeting rooms. So typically on an interview day with Forbes, you'll have 20-minute meetings with 2 of the faculty, myself, and 1 of the residents, sometimes 2 of the residents, it kind of depends, but those are on an individual basis. And then at the end, you'll meet with our office manager, Gil, who's wonderful. And he kind of tells you more about the practice, just the center itself. And then I do a wrap up at the end with Gina. So, kind of closing out questions if there are additional things. And the other thing that we do offer, so typically at the end of that wrap up session, we'll say, if anybody here has any, particular interest, so, somebody says, I really want to talk with, Dr. Wolf about HIV care and how that's incorporated specifically into the program, then we can set up a separate Zoom, for you to meet with him, or one of the other faculty if there's something else that you're interested in, just to get more specifics on that particular thing. So that's sort of how it works overall. It's really a half a day. You're usually done by about 11:30, something like that. So I think it's hard to Zoom for hours and hours. It wears on you, after a time, kind of going in and out of the rooms and that type of thing. So we try to keep it to the morning for the most part.
And just a regular question, not regarding the interviews. From the AFP conference from one of your residents, I got to know we get paid extra 12,000 for admitting patients from different preceptors. Is it true?
Yeah, so they're not admitting the patients. It's called a tuck-in service. And so sometimes the community docs, let's say they're in their office, and they're working late or something, and one of their patients gets admitted. Sometimes, and this is just for the evening, so between 6 p.m. and 6 a.m. is when this service is available, they can call the resident and say, hey, I admitted Mr. Jones this morning. I'm a little concerned, about this or that. Do you mind doing a tuck-in and just going to check on him, essentially, or do you mind repeating his potassium and checking on it and letting me know what it is, or that type of thing. So they do get extra pay for that. And the residents love it. They love the tuck-ins. And so again, I think it's a nice service, for the community docs that the residents provide. They're getting paid to do it, so they enjoy that extra compensation. And yeah, overall, it works out pretty well, I think. That is true.
Thank you.
Sure.
I'm also wondering about, do you have a structured mentoring program, and how does that work out for the residents?
Yeah, absolutely. So every resident, when they come in, we have teams. So we sort of divide the entire group into teams or pods. And so each pod will have a faculty member, a 3rd year, 2nd year, 1st year. It has typically an MA involved and a health coach. And so that's sort of your team. And so when it comes to like OB continuity patients, or let's say you're in the ICU and you really want a patient of yours to be seen, typically you would hand that off, do like a warm handoff to somebody on your team. and they would, go ahead and see that patient. So within that, we try to pair up that faculty member with each of those residents to say, okay, this is your advisor, you're one of their advisees. You will meet usually twice a year with your advisor to sort of go through what your goals are, where you're at in your training, any of your evaluations, those types of things. And then usually all the residents meet with me twice a year too, to sort of do the same. And so I usually meet with the residents at the middle of the year and the end of the year, and they sort of do the beginning and the third quarter. So there's always somebody sort of mentoring you, looking at what your interests are, and kind of talking to you and helping you to sort of develop like your individual education plan to say, okay, this is what I want to do for my longitudinal. This is the QI project I want to do. This is my scholarly activity. And so somebody's always kind of working with you on those things. And your senior residents are excellent too, as far as just helping you kind of navigate through that, for sure. I feel like we're always giving feedback, to the residents. We actually started a new thing this year. After your week of inpatient, we do something called Feedback Fridays. And so every Friday, sort of at the end of your inpatient week, we sit down with each resident individually, just like a 5-minute, thing. This isn't too in-depth, but just like a 5-10 minute discussion of, this is what I think you did really well. This is, some things I think we should work on and, maybe grow here or there. But that way, I think there's no surprises. You want to sort of know how you're doing as things are going.
Thank you. And I think that would work very well for the residents, I'm sure. Thank you for sharing that.
Sure, of course. Anything else, guys? We've covered a lot of ground. We certainly have. Well, if there's nothing else, we can sign off here and give you an hour back of your life, 45 minutes at least. But I really, I enjoyed meeting all of you and getting to know you, and you asked great questions, I think about the program, about family medicine in general. And I'm proud to sort of welcome you to the community of family medicine. I think, you seem all very passionate about it, and really motivated to do great things. So welcome. And if you have any other questions or anything, feel free, you could send a message to me at the program. Gina Sacco, our residency coordinator, you could certainly reach out to her as well with any other questions, and I'll be happy to field those afterward too.
Great.
Thank you so much. Thank you for your time.
Absolutely. It was nice
you.
talking with all of you.
Nicola.
Thank you, everyone.